So we'll just wait for students to join.
Ma'am, yes, you are live now.
Yeah, hello.
Ma'am, you are live now. Oh, you can start. Yes, ma'am, you can start now.
Hello everyone. So welcome back after the break. So you can just scan this code to join the group. So that you are kept informed about the class break timings and the session updates. So you can just scan this and get into the group. Yes, let's move on to the other part of neurophysiology. So let's do neuromuscular junction. Neuromuscular junction. Yes, I think slowly students are joining. Yes, for those who have joined just now, just an information about the group. You can just scan the code to join the group so that you are kept informed about the class break timings and session updates. Is over to neuromuscular junction. Neuromuscular junction is a very, very important topic in nerve physiology, as well as there are many clinical aspects also here. So we'll do the neuromuscular junction. The NMJ, neuromuscular junction. This is the junction between the neuron and the muscle. Very simple. Neuromuscular junction means the junction between neuron and the muscle. So we'll draw the neuron. So those who joined late, I'm just starting off with the neuromuscular junction. Just now we started with the neuromuscular junction. Yes, you can draw this along with me. The structure of neuromuscular junction. We'll draw a neuron. This is the neuron. On the other side, I'll draw the muscle. Now this junction between neuron and the muscle is called the neuromuscular junction. So this yellow space is the neuromuscular junction. So I can call this neuron as presynaptic. Presynaptic means it is present before the synapse. And muscle is called postsynaptic because it is present after the synapse. So presynaptic neuron, postsynaptic muscle. What are the events happening in the neuromuscular junction? Whenever a neuron is stimulated, the first thing that happens is opening of voltage gated sodium channels and sodium entry. Whenever sodium enters inside, wherever sodium enters, there is an action potential. You have depolarization and an action potential. This action potential travels along the neuron, reaches the axon terminal. Whenever an action potential or depolarization or voltage reaches the axon terminal, this voltage will be sensed by voltage gated calcium channels and there is calcium entry. Calcium enters inside. Wherever you have calcium, what is the role of calcium? Calcium will always do a movement. So calcium will do a movement. What is the movement here? Movement of vesicles. So these vesicles contain acetylcholine. The calcium will move the myofilaments. Exactly, Ranjan. Myofilaments or the vesicle, whatever it is, it will move. So this will move the vesicles to release acetylcholine. Now, acetylcholine is released into the neuromuscular junction. For those who have joined late, I'm just repeating. We are learning the structure of neuromuscular junction. This is the yellow space, neuromuscular junction. Before the NMJ, you have the neuron. After the NMJ, you have the muscle. In the neuron, what are the steps? First step, sodium entry. There's an action potential. Action potential is sensed by voltage gated calcium channels, calcium entry. Wherever there's a calcium, there is movement. The movement of vesicles to release the neurotransmitter acetylcholine. Now, what is the fate of this acetylcholine? This acetylcholine crosses the neuromuscular junction to bind to its nicotinic receptors. So, where are these nicotinic receptors present? Nicotinic receptors are present on the muscle. So acetylcholine binds to the nicotinic receptors. Once acetylcholine binds to the nicotinic receptors, the same four steps will repeat in the muscle. Very simple, same four steps. What is the first step? Voltage gated sodium channels. Exactly same. They open and sodium entry. Number two, whenever there is sodium, there is an action potential. Now this is the muscle. Action potential enters into the muscle whenever there is an action potential entering into the muscle. Next step is calcium. But there's a small difference here. In a neuron, calcium entered from outside. From outside, calcium is entering. But in a muscle, already a muscle has stores of calcium. That is called SR. So the SR, sarcoplasmic reticulum, releases calcium. In the neuron, calcium comes from ECF. But in the muscle, cell itself has calcium. The stores are called SR, sarcoplasmic reticulum. And number four, whenever there is calcium, there should be a movement. What is the movement? Movement of myofilaments. Actin and myosin. When actin and myosin move, the whole muscle moves. So these are the steps in neuromuscular junction. The steps are very important. Four steps in the neuron, same four steps in the muscle. Now, what is the clinical importance related to this? These voltage gated sodium channels, there are blockers of these channels. They are called as tetrodotoxin. Tetrodotoxin. Tetrodotoxin is a blocker of voltage gated sodium channels present in puffer fish. If you don't cook puffer fish properly, this poison can attack your muscles. So this is tetrodotoxin, blocker of voltage gated sodium channels. Another disease related to the voltage gated calcium channel, auto antibodies. Yes, what is this disease? Ranjan, Hadia Sai, Dheeraj, Swanil, Pranjali. Yes, Lambert-Eaton. Very good. Very important. LES, Lambert-Eaton syndrome. So Lambert-Eaton syndrome is a presynaptic disease of the neuromuscular junction because it is happening in the neuron. Autoantibodies against the calcium channel. It's a presynaptic disease. What is the postsynaptic equivalent of this? If you have autoantibodies against the nicotinic receptor. Excellent, Swanil. This is called myasthenia gravis. Myasthenia gravis. So please remember, Lambert-Eaton syndrome is a presynaptic disease, whereas myasthenia gravis is a postsynaptic disease. The other disorders related to this, acetylcholine. Once its function is over, this would be degraded by acetylcholine esterase. There is a poison which is a blocker of acetylcholine esterase, OPC, organophosphorus compounds. If you block acetylcholine esterase, acetylcholine is not degraded. Therefore, more acetylcholine. Acetylcholine is parasympathetic, more parasympathetic activity. The most important function of parasympathetic activity is secretions. So this would increase the secretions. That's why OPC poisoning, organophosphorus compound patients, they are usually it is present in insecticides and pesticides like parathion and malathion. When you see these patients, how they bring the patients to the casualty, they'll have lot of secretions around the mouth, frothing, bubbling around the mouth. So if you see lot of secretions around the mouth, you can think of OPC poisoning. There are also drugs which do the same. Blockers of acetylcholine esterase, physostigmine, neostigmine, physostigmine and neostigmine. Physostigmine and neostigmine, not botulinum. Dheeraj, it is not botulinum. Botulinum toxin is different. It is a blocker of SNAR protein. Okay, so don't confuse botulinum. I will come to botulinum. This is used in the treatment of myasthenia gravis. Yes, in the treatment of myasthenia gravis. Yes, over to your botulinum toxin. For these vesicles to release acetylcholine, we need SNAR proteins. So this step is helped by SNAR proteins. What are the SNAR proteins? Synaptotagmin, synaptobrevin, syntaxin, and SNAP25. These are all SNAP proteins. SNAP proteins, what is the function? They'll help to release acetylcholine. Now, yes, over to Dheeraj, your botulinum toxin, Clostridium botulinum. It is a blocker of SNAP protein. What will happen if you block the SNAP proteins? When SNAP proteins are blocked, acetylcholine decreases. When there is no acetylcholine, contraction decreases. When contractions decrease, muscles become very loose and flabby. That is called flaccid paralysis. Flaccid paralysis. This is in contrast to Clostridium tetani. Clostridium tetani is a blocker of GABA and glycine. GABA and glycine are inhibitory neurotransmitters. If you block inhibitory neurotransmitter without inhibition, it will cause more acetylcholine activity and therefore spastic paralysis. So that is Clostridium tetani. It is a blocker of GABA and glycine. GABA and glycine are inhibitory neurotransmitters. If you block the inhibitory neurotransmitter without inhibition, acetylcholine increases, more contraction results in spastic paralysis. Spastic paralysis. So Clostridium botulinum flaccid paralysis, Clostridium tetani spastic paralysis. Don't confuse both. Yes, these are all the clinical importance related to the neuromuscular junction. Yes, one more I'll tell you. SR. SR releases calcium with the help of two channels, ryanodin channel and dihydropyridine. Ryanodin and dihydropyridine. Dihydropyridine itself is a voltage gated calcium channel. So SR releases calcium through ryanodin and dihydropyridine. There is a disease where the patient has overactivity of ryanodin and dihydropyridine. If they act too much, more calcium is released. More the calcium, more the muscle contraction. More the muscle contraction, more heat is produced. This is called malignant hyperthermia. Malignant hyperthermia. Malignantly, so much of heat is produced. Malignant hyperthermia. How will you treat this? Yes. Can you tell me how would you treat this? Malignant hyperthermia, overactivity of ryanodin. So you give a ryanodin receptor blocker. Excellent. Yes. Dantrolene sodium. Dantrolene sodium. Dantrolene sodium is a ryanodin receptor blocker. Just go through this again. Very important, NMJ. Next, let's move on to basal ganglia and cerebellum. Two small topics but high yield topics. Basal ganglia and cerebellum. The nucleus of basal ganglia. First, you should know what are the different parts of the basal ganglia. Basal ganglia, in the center you have thalamus. Thalamus is not a part of basal ganglia. Thalamus is in the center. On both the sides of the thalamus, basal ganglia nucleus will be distributed. So I will draw one half of the basal ganglia here. One half we will draw. The other half is on the other side. So we'll draw for one half of the brain, we'll draw the basal ganglia. The nucleus, listen carefully, nucleus of basal ganglia. Basal ganglia has a C-shaped nucleus called C for caudate nucleus. And there is a lens-shaped nucleus, lens-shaped. So it is called lenticular nucleus. Lenticular nucleus is made up of putamen, globus pallidus external and globus pallidus internal. Putamen plus caudate, P plus C. Together it is called striatum. Just below the thalamus, subthalamus. subthalamic nucleus, just below the thalamus. Even below that, substantia nigra. This is subthalamic nucleus and substantia nigra. Substantia nigra is made up of pars compacta and pars reticularis. So these are all the different nucleus, the parts of the basal ganglia we have done. Next we'll see what are all the connections of the basal ganglia. There are important inputs and outputs. On top of basal ganglia, we have motor cortex. So the most important connections of basal ganglia are with thalamus and motor cortex. What are the inputs? Basal ganglia receives input from cortex into striatum, which is plus. This is called corticostriate input. The other input from thalamus into striatum, this is also plus. This is called thalamostriate input. So two inputs, corticostriate, thalamostriate. What is the output of the basal ganglia? We have one output from GPI to thalamus. This is inhibitory. So the output is inhibitory. And please remember, thalamus is always connected to the motor cortex. That's a connection between thalamus and motor cortex. So what are the inputs into the basal ganglia? Corticostriate, thalamostriate, both are excitatory. What are the outputs? GPI inhibits thalamus, that is an output. And thalamus in turn is connected to the motor cortex. Now, what are the functions of the basal ganglia? Functions of basal ganglia. The main function is to keep you at rest. At rest. At rest means you don't do any movement. When you are at rest, GPI inhibits thalamus. This one. When you are at rest, GPI inhibits thalamus. When thalamus is inhibited, we already said thalamus has a connection to the motor cortex. So whenever you inhibit the thalamus, motor cortex also will be inhibited. When motor cortex is inhibited, you can't make any movements. That's why you are at rest. So at rest, GPI inhibits thalamus. When thalamus is inhibited, motor cortex is inhibited. That's why you are at rest. So GPI inhibits thalamus and therefore motor cortex also inhibited. That's why you are at rest. You're not making any movement. If motor cortex is not there, you can't make movement. Now you want to start a movement. From rest, you're going to start a movement. So when you want to start a movement, to keep you at rest, you need this inhibitory connection. When you want to start the movement, you should remove the inhibitory connection. That inhibition will always keep you at rest only. So if you want to start a movement, you remove this inhibitory connection. GPI inhibiting thalamus and therefore motor cortex should be inhibited. Who will remove this inhibition? Striatum will do this for us. Striatum. So striatum will remove this inhibitory. If you remove the inhibition, you can start the movement. Now you are making the movements. Again, you want to come back to rest. You want to stop the movement and you want to come back to rest. So when you want to stop the movement and come back to rest, who will keep you at rest? This inhibition only will keep you at rest. But this inhibition was removed by striatum. Now you need somebody to bring this inhibition back. Who will activate this again for us? Very good, subthalamic nucleus. Now you need somebody to activate this inhibitory connection. Who will activate this for us? Subthalamic nucleus. Subthalamic nucleus will activate this again for us. So you will come back to rest. Starting the movement is called as direct pathway and stopping the movement and coming back to rest is called indirect pathway of basal ganglia. So this is the function of basal ganglia. Most important function to keep you quiet at rest. That is why any disorder of basal ganglia, the patient is not able to keep quiet at rest. At rest itself, he'll be making some involuntary movement. He'll move his neck, hands, legs. So he's making some involuntary movement. He's not able to keep quiet at rest. So what are all these movement disorders? What are the diseases related to the basal ganglia? So we'll see one by one what are all the disorders related to the basal ganglia. So first, subthalamic nucleus. If there is any damage to the subthalamic nucleus, excellent Ranjan, that we call it as hemibalism. Ballet is a dance. Hemibalism means one half of the body, hands and legs are moving. Ballet type of dance. The next one, if there is any damage to the striatum, chorea, this is called chorea. Choreography means dance. So chorea means dance. This can especially happen in rheumatic fever. Children affected by rheumatic fever, they have a tendency for damage to striatum. So that is called as Sydenham's chorea. Sydenham's chorea. In rheumatic fever, it's called Sydenham's chorea. From substantia nigra, pars compacta to striatum, there is a dopamine producing pathway. That is called the nigrostriatal pathway. It goes from nigra to striatum. It's called nigrostriatal pathway, produces dopamine. And any loss of this dopamine fiber is called, very good, Parkinsonism. That's why we treat Parkinsonism by giving levodopa. Dopamine cannot cross blood-brain barrier, so we give levodopa. When there is any damage to GPE, athetosis, it's a disorder related to the fingers, movements of the abnormal movements of the fingers. Excessive copper deposition in the lenticular nucleus, Wilson's disease. That's why it is called hepatolenticular degeneration, because you have copper deposition in the hepato means liver. Lenticular means lenticular nucleus of the basal ganglia. So hepatolenticular degeneration is Wilson. What is that eye finding in Wilson? Yes, what is that eye finding in Wilson's disease? Kaiser-Fleischer ring. Very good. Kaiser-Fleischer ring. From striatum to GPE, there is an inhibitory connection. If there is any damage to this fiber, Huntington's disease. From striatum to GPE, there is this is an internal connection, inhibitory connection. If that is damaged, Huntington's disease. All these are related to movement. There's one disorder not related to movement, but cognition will be affected. C for caudate, C for cognition will be affected. So when there's any damage to caudate, cognition disorder. Cognition means the patient is not able to understand, intelligence, learning, all this will be affected. So these are all the disorders related to basal ganglia. Over to cerebellum. What are the parts of the cerebellum? Cerebellum has cerebrocerebellum, spinocerebellum, vestibulocerebellum. The lateral portions are called as cerebrocerebellum. The lateral portions, and cerebrocerebellum receives the plan from the cerebral cortex. That's why it's called cerebrocerebellum. It gets the plan from the cerebral cortex. So if there is any damage to the cerebrocerebellum, planning will be affected. So this results in delay in initiating movement. Delay in initiating movements. Any damage to cerebrocerebellum. Spinocerebellum, this one connects to spinal cord and therefore to the muscles. It helps in coordination of the muscles. This is helping in coordination. So if there is any damage to spinocerebellum, this results in incoordination. Incoordination is called as ataxia. That's what we call it as cerebellar ataxia. So what are the different types of ataxia? What are the different types of incoordination that is seen? Ataxia is of different types. Dysmetria. Incoordination of distance is called dysmetria. Not able to measure distance. So you ask the patient to pick up the bottle, the hands will go forward. That's called past pointing. He can't measure the distance. He'll go forward, come back, go forward, come back. This results in a tremor. This is called intentional tremor. Incoordination in doing alternate activities. Yes, how will you ask the patient to do alternate activity? Like this. This was a last year repeat question. Dysdiadochokinesia. If you are able to do alternate movement, that is diadochokinesia. If you are not able to do this, that is called dysdiadochokinesia. So in cerebellar disease, patient will have dysdiadochokinesia. He cannot quickly alternate like this. He will only do like this. He can't quickly alternate like this. Dysarthria. In coordinated speeches, dysarthria. Rebound phenomena. You just ask the subject to flex the elbow like this. You give resistance in the opposite direction. He is flexing, you resist that. Suddenly you remove your hands, he'll go and hit on his face. This is called rebound phenomena because he doesn't know how to stop this movement, how to coordinate the movement. Suddenly if you remove your hands, they will hit on the face. This is called rebound phenomena. So all these are related to spinocerebellum. Damage to spinocerebellum results in ataxia. In the center of spinocerebellum, there is a vermis. So vermis is also a part of spinocerebellum, but since it is in the centermost part, it will control the coordination of centermost muscles of the body. What are the centermost muscles of the body? Trunk muscles of the body. So trunk muscle coordination is by vermis. Vestibulocerebellum. Vestibulocerebellum is made up of nodulus and flocculus. Therefore, it is called as flocculonodular lobe. Vestibulocerebellum. What are the functions? Anything related to vestibular apparatus means balance. So it helps in balance, equilibrium. If you are able to maintain your balance and equilibrium, you can maintain your gait. The way you walk is called as gait. Nodulus and flocculus are related to eyeball movements. So this helps in eye movements. That is called vestibulo-ocular reflex. Vestibulo-ocular reflex or doll's eye movement. When head rotates to one side, eyeball will go to the opposite side. That is called doll's eye movement. So, if there is any damage to vestibulocerebellum, this will result in disequilibrium, drunken gait, alcoholic gait, eye movements are affected. That is called nystagmus. When there is any damage to vestibulocerebellum, disequilibrium, nystagmus, and alcoholic gait or drunken gait. So next, let's see the different nucleus of cerebellum. Deep inside the nucleus, deep inside the cerebellum, we have 4 different nuclei. The mnemonic is doctors eat good food. Actually, no, but the mnemonic is doctors eat good food. D, E, G, F. So from outer to inner, outermost is D, dentate, emboliform, globose, fastigial is innermost. So the mnemonic is doctors eat good food. This was a repeat question. Which is the innermost nucleus of cerebellum? Fastigial. Cerebellum has an outer cortex and an inner nucleus. What is that connection between the outer cortex and the inner nucleus? That is called cerebellar connections. Very important connections of the cerebellum. Yes, you remember we learned it with the help of a story. Quickly, I'll go through that. The story goes like this. This is the connection between cortex and the nucleus of the cerebellum. Once upon a time, there was a deep nuclear family. So I'll write deep nuclear family. The head of the family was grandpa. And this grandpa had 4 grandsons. All of them entered into medical colleges, but in different mode. The first boy, he entered into medical college in GC category, general category. The other one in BC, the other one in SC. One who did not get in any of the government college, he went into private college, PC. This grandpa is so good that whatever plus he has, he will give it equally to his grandsons. Plus, plus, plus and plus. But these boys are very bad. See, this first boy, GC, he is getting plus from the grandpa and he is inhibiting the grandpa itself. This is like backstabbing, getting from the grandpa and inhibiting the grandpa itself. He is doing backstabbing. So this is called as feedback inhibition. Backstabbing. So feedback back inhibition. The other two boys, BC and SC, they don't have guts to go back and inhibit the grandpa. They are going forward and they are inhibiting this boy, PC. They are going forward on this boy. So this is called feed forward inhibition. And this boy, PC, he doesn't know what to do. Now he is inhibiting the whole family. Although so many confusions are going on inside the family, this family as a whole, it will get plus from outside, and in turn also it will give back plus only. So now coming back to cerebellum, deep nuclear family indicates the 4 deep nucleus. Doctors eat good food, DEGF. Which cell sounds like gran in the cerebellum? Granule cell. GC stands for Golgi cell. BC for basket cell. SC for stellate cell. And PC Purkinje cell. Now let's do the connections of cerebellum. Listen carefully. I'll tell you the points in cerebellum. Granule cell is the only excitatory cell of the cerebellum. Yes, because it is giving plus everywhere. So granule cell is the only excitatory cell of the cerebellum. Golgi cell inhibits granule cell. This is called feedback inhibition. Basket cell and stellate cell inhibit Purkinje cell. This is called feed forward inhibition. Purkinje cell is the net inhibitory connection between all the cells in the cortex and the nucleus. Purkinje cell is the net inhibitory connection between all these cells in the cortex and the nucleus. Yes. All inputs into the cerebellum are excitatory. Yes. The net output of the cerebellum is also excitatory. Yes. Now, what are the names for these inputs? This is called climbing fiber, and the other one is mossy fiber. The climbing fiber, one climbing fiber will connect to one Purkinje cell. This is called 1:1 connection. So this will give you a very strong spike, compound spikes. One mossy fiber will connect to 1 million granule cell. This is a 1:1 million connection. So this is a weak connection. Whereas 1:1 is a strong spike. 1:1 million is a weak spike. So that is about the cerebellum. It's over to. Now we have finished sensory nervous system and motor nervous system. So we can go forward to Brown-Sequard syndrome. What is Brown-Sequard syndrome? Hemisection of the cord is called Brown-Sequard syndrome. One half of the spinal cord has been damaged. That is called Brown-Sequard. For example, let's say this left half of the spinal cord has been damaged. This is right. So on the left half of the spinal cord, there is a damage. What will be the clinical presentation? Hemisection of the cord. Cause could be anything, a gunshot injury, a stab injury, or there's a tumor on one half of the spinal cord. So what are the clinical features of Brown-Sequard syndrome? We will just trace the pathways. At the level of spinal cord, everything will be lost. At the same level as injury, we don't care about that. Everything is lost. Below the level of injury to the spinal cord, what are all the clinical presentations? We will trace the sensory and motor tracts. What are the two sensory tracts? Dorsal column, spinothalamic tract. So the dorsal column, carrying sensation from left half of the body, enters into the spinal cord, ascends into the medulla, crosses in the medulla to the opposite side like this. Because we already know dorsal column crosses in the medulla. So dorsal column sensations carried from left half of the body are passing through the damaged portion of the cord. So on the left half of the body, you will lose dorsal column sensations. Number one, dorsal column will be lost. Yes, if this is cut, the same side dorsal column sensations will be lost. Spinothalamic tract. Spinothalamic tract from the same half goes into the spinal cord, but spinothalamic tract fibers Why it's called spino? Because they cross in the same segment of the spinal cord. So spinothalamic tracts, they will cross in the same segment, go to the opposite side like this. So they are actually not passing through the damaged portion of the cord because they have already passed to the opposite side. They have already crossed to the opposite side. So this will escape. But what about the spinothalamic tract from the opposite half? So we'll trace the spinothalamic tracts from the opposite half. Spinothalamic tracts, opposite half enters into spinal cord, crosses to the opposite side like this and ascends up into the sensory cortex. So now spinothalamic tract carrying sensation from right half, opposite half is passing through the damaged portion of the cord. So this will be lost. So on the opposite side, the finding is spinothalamic tract will be lost. It means pain and temperature will be lost. So same side dorsal column sensations are lost, but opposite side pain and temperature is lost. What about the motor tracts? We have the corticospinal tracts. The motor tract is corticospinal tract. The corticospinal tracts cross in the medulla, come down like this to supply this half of the body. So this corticospinal tract is lost. On the same half of the body, patient will have paralysis. So number 2, corticospinal tracts are lost. Therefore, hemiplegia. Corticospinal tract is a UMN tract. Therefore, the patient has UMN type of lesion on the same half. If this corticospinal tract is lost, it is coming down to supply this half of the body. So this same half of the body, hemiplegia will be present. So to summarize, in Brown-Sequard syndrome, on the same side, or that's called the ipsilateral side, dorsal column sensations are lost, corticospinal tract is lost, patient has hemiplegia and UMN lesion. On the opposite side, pain and temperature is lost. So I'll tell you a repeat question in medicine. Tell me true or false. Just tell me true or false. T or F. Same patient, when this patient has left side damage to the spinal cord. On the left side, patient experiences hypertonia, hyperreflexia and Babinski sign positive. True or false? On the same side, patient is experiencing hypertonia, hyperreflexia, Babinski sign positive. Yes, excellent. Kush, Pranjali, Swanil, Harya, very good. It is true because it is a UMN type of lesion on the same side. What are the findings of UMN? Upper motor neuron, three things are up. Hypertonia, hyperreflexia and toes go up. So that is about Brown-Sequard syndrome. Over to hypothalamus. Hypothalamus has different nucleus. Yes, somebody asked for hunger nucleus. We'll discuss here. How did we learn this? Just imagine hypothalamus like a car. What are all the different nucleus and their functions? Anteriorly in a car, you have AC. AC gives you cooling. So anterior hypothalamus, what is the function? Cooling. How does it help you in cooling? Because you have the thirst centers here. By stimulating thirst, anterior hypothalamus helps you in cooling. And also it can enhance sweating and vasodilation. All these are mechanisms of cooling your body. Posterior hypothalamus. Posteriorly in the car, we have silencer and silencer produces heat. So posterior hypothalamus, heating effect on the body. How can you heat your body? Yes, you shiver. When you shiver, muscles are contracting, heat is produced. So this is shivering. By shivering mechanism, posterior hypothalamus produces heating. Please don't confuse these statements. Listen to this. Anterior hypothalamus produces cooling. But when will anterior hypothalamus produce cooling? In response to heating of the body. So whenever your body is heated up, in response to heat, anterior hypothalamus will produce cooling. Posterior hypothalamus produces heating. When will it produce heating? When your body is getting cool, it will produce heating. So posterior hypothalamus, in response to cooling of your body, it will produce heating. So don't confuse. Just see if they are asking in response to what or the function. Don't get confused. Lateral and medial hypothalamus. Just imagine 3 people are sitting on the back seat, 2 people near the window. When you are near the window, you can just buy something and you can just open the window, buy something, you can just keep on eating. So 2 people sitting laterally, they are just eating. Feeding center, and by looking at some sceneries, they can remain awake. So feeding, lateral nucleus, this helps in feeding. Hunger center, and also wakefulness. Excellent. All of you are answering so much. Thank you so much. So I'm so happy to see all the responses. You are all fully prepared for the exam. Good. Feeding and wakefulness. Medial hypothalamus. Medially, one poor person is sitting in the center. He is not near the window, so he can't buy and eat. Opposite of feeding. Opposite of feeding is satiety. Satiety means stomach fullness, always in a state of stomach fullness. But he is seeing these lateral people are eating nicely. So he's getting angry, anger. He's becoming aggressive, aggression, anger and aggression. There are some chemical substances which will help in this. Lateral hypothalamus, the substance is ghrelin. Ghrelin acts on lateral hypothalamus to increase feeding. Medial hypothalamus, leptin. Ghrelin is an orexin. So orexins like ghrelin, feeding, leptin, satiety. Yes, loss of that orexin is called narcolepsy. Arcuate nucleus. Arcuate nucleus can do both. It can increase or it can decrease feeding. Both it can do. And it can produce all releasing hormones except GnRH, which is produced by preoptic area. All releasing hormones of hypothalamus, CRH, TRH, growth hormone releasing hormone, prolactin releasing hormone, all releasing hormones of hypothalamus come from arcuate nucleus except gonadotrophin releasing hormone which comes from preoptic area. Suprachiasmatic nucleus. Supra means on top. Yes, what is that opening on top? Sunroof or moonroof. Sun and moon is related to day and night cycle. Day and night cycle is called circadian rhythm. Supra means top. On top, that opening is called sunroof or moonroof. So this is circadian rhythm. Supraoptic and paraventricular nucleus. Supraoptic, paraventricular. You have an O and V there. O and V stands for O hormone oxytocin, V hormone vasopressin. Both are hormones of posterior pituitary. O hormone oxytocin, V hormone vasopressin. Remember, both can produce both oxytocin and vasopressin. Oxytocin and vasopressin. But exactly, if you measure, there's a small twist. Supraoptic will produce more of V hormone vasopressin. See, there's a small change. Both will produce both, but optic will produce more of vasopressin and paraventricular V will produce more of oxytocin. It's a small twist there. Mammillary body. Mammillary sounds like memory. So this is memory, and any damage to this mammillary body results in Wernicke-Korsakoff syndrome. This is seen in B1 deficiency, vitamin B1. Repeat question for you. Thiamine or vitamin B1 deficiency and alcoholism. You can see Wernicke-Korsakoff syndrome. There's a damage to this mammillary body. Preoptic area. Preoptic. Pre for pre. Pressure. So this can decrease blood pressure. It can decrease heart rate. Pre for pre. It can decrease blood pressure. It can decrease heart rate. So this is about the different nucleus of hypothalamus. Very important nucleus of hypothalamus and their functions. Over to sleep physiology. Nice time to learn sleep physiology. I can teach you the theory, and I think already some of you are experiencing practically the stages of sleep. So, what are the stages of sleep? When you say good night and you go to sleep, we start our sleep in NREM, non-rapid eyeball movement sleep. When you say good morning and you get up in the morning, we get up from REM sleep, rapid eyeball movement sleep. Throughout the night, there is a switchover. Every 90 minutes, there is a change between NREM and REM. This is called ultradian rhythm. The sleep wake cycle is circadian rhythm. Only the night sleep cycle is ultradian rhythm. Overall, if you calculate, 75% of the sleep is spent in NREM, only 25% in REM. What are the differences between NREM and REM sleep? Listen carefully, very important. NREM sleep. This is called as quiet sleep. Why it's called as quiet sleep? Because you are sleeping quietly without any eyeball movement, and also sympathetic is inactive. If sympathetic is inactive, you will sleep quietly with less heart rate and less BP. REM sleep is called active sleep. Why it's called active? Because actively rapid eyeball movements, and also sympathetic is active. If sympathetic is active, you're sleeping with high heart rate and high BP. NREM. N for not, REM for remembered. Not remembered. What is not remembered? If you have a dream in the NREM sleep, you will not remember that in the morning. What are the other things that happen during the night and you don't remember in the morning? Only your roommate will tell you you did all this in the night. Yes, they are all somnambulism, sleep walking, somniloquy, sleep talking, bruxism, teeth grinding, enuresis, bedwetting. So all these are not remembered. It happens in the night and you don't remember in the morning. Only when somebody else tells you will know. REM for remembered. What is remembered? If a dream happens in REM sleep, you can remember it in the morning. Why you are able to remember? Because of PGO spike. It's an electrical activity which starts in the pons, goes to geniculate nucleus and occipital lobe. Ponto, geniculo, occipital spike. So it's an electrical activity which is hitting on your occipital lobe. Ponto, geniculo, occipital spike. Because it's hitting on the occipital lobe is vision. That's why if a dream happens during that period, this PGO spike will make you to visualize the dream. So you can remember the dream. What about muscle tone? Muscle tone slightly decreased in NREM sleep. Why only slightly decreased? Because you have to do walking, talking and all. You need muscle tone. So only slightly decreased. But in REM, muscle tone is completely lost. That is called sleep paralysis or cataplexy. Muscle tone completely lost, sleep paralysis or cataplexy. The first muscle to lose the tone is neck muscle. So this is about the differences between NREM sleep and REM sleep. Important. What are sleep waves? Sometimes if a patient has a sleep disorder and you want to identify in which stage of sleep he is experiencing this sleep disorder, we can do an EEG study. You connect electrodes all over the scalp, you ask the patient to sleep, and you record the electrical activity of his brain throughout the night. From the point when you start sleeping until you get up in the morning, the brain will record different types of EEG waves. That's called the sleep wave. Let's see what are all the sleep waves. The mnemonic is at night, bats, drink, blood. At night means we are recording the electrical activity of the brain during the night when the patient is sleeping. Bats, B, A, T, S, drink, blood. This is the mnemonic. We'll arrange it in this way. BATS, drink, blood. When you start to sleep, what is the first part of the sleep? You will not sleep immediately. You go to the bed, you are not sleeping immediately. You will remain awake for some time with your eyes open. So initially, your brain will record beta waves when your eyes are open. You are still awake. You didn't sleep. You are still awake. Then what you will do? You will close your eyes, you will relax, and you will try to sleep. A for alpha waves. Eyes closed and relaxed state. You're trying to sleep. Suddenly, if your exam date comes to your mind, oh my god, whether I'm going to pass or fail, or you become too much of stressful, alpha will change into beta. This is called alpha block or alerting response or desynchronization. It is alerting you, it is not allowing you to sleep. So only if you forget about all that, you will be able to sleep. That's why during the exam time, you won't get sleep because you'll enter from beta to alpha. Suddenly your exam will come to your mind, pass, fail, family, all that will come to your mind. You will go from alpha to beta again. Every time you try to sleep, you will be circulating in alpha block itself. Only you forget about everything, you will go into sleep. Now, theta waves, first stage of sleep. NREM 1. This is the first stage of sleep. See, this is not the first stage of sleep. Beta and eyes open is not first stage of sleep. Theta and NREM 1 only is first stage of sleep. Then S for sleep spindles along with K complex. NREM 2. Then D for delta waves. NREM 3. Sometimes NREM 4 also is included here. Then B for beta waves. REM sleep. Then you enter into REM sleep. REM sleep is called paradoxical sleep. Paradox means something which is not agreeing. Controversy. What is the controversy here? Beta waves should be obtained when you are awake. But why do you get the beta waves in REM sleep? That's a controversy. But actually, why do you get? Because of PGO spike. Pontogeniculo-occipital spike. This is an electrical activity. When it hits on your occipital cortex, you're getting an awake-like state. That's why you're getting the beta waves there. So these are the different waves that you see. And what are the features for each? Sleep stage 1. More prone for hypnic jerk. You will be sleeping, you have a feeling that you climb on a mountain. You just lift your legs and see nothing would have happened. You have a feeling that you climb on a staircase, but you wake up and see nothing would have happened. That is hypnic jerk. NREM2 is prone for bruxism, teeth grinding, and NREM2 contributes to 50% of the sleep. Overall, NREM is 75%. In that, NREM2 alone is 50%. NREM3 is more prone for walking, somnambulism, and bedwetting, enuresis, and enuresis. So these are the features for different stages of sleep. When you identify with the diagram, beta waves they have the highest frequency because they are occurring more frequently, very closely spaced, but the height is very less, amplitude is low. But delta waves, they have highest amplitude and frequency is very low because they are occurring less frequently only. There is more gap. They are occurring less frequently. There is more gap. This is about how you identify them with the help of these waves. Yes, over to speech physiology. So in speech physiology, the speech areas, very, very important speech physiology, small topic, but repeatedly you see questions. First, let's do the speech areas. Wernicke's area responsible for comprehension. Comprehension means understanding something. If I talk to you, you should understand. That is by Wernicke's area, Broadman number 22. From Wernicke's area, it connects to Broca's area, and Broca's area is Broadman number 4445. This is called the fluency area or the motor area. Motor means it is going to help you in motor speech. It is going to help you. It is going to connect to the motor cortex. It is going to make you to move your muscles to speak. So two important areas, Wernicke area and Broca's area. See where they are located. Broca's is on top, on the frontal lobe. Wernicke's is down, on the temporal lobe. This is frontal and this is temporal lobe. Now, what are the different types of aphasia? If there's any damage to Broca's area, it is called Broca's aphasia. Damage to Broca's area, number 44, 45. This is supplied by superior branch of middle cerebral artery. Yes, obviously Broca's is on top here. So it will be supplied by superior branch of middle cerebral artery. Wernicke's aphasia, damage to area 22, infarct to inferior branch of middle cerebral artery. Yes, because Wernicke's is down, it is supplied by inferior branch of middle cerebral artery. Both are affected, global aphasia. Conduction aphasia, damage to arcuate fasciculus. What is arcuate fasciculus? The conducting bridge between Wernicke's and Broca's. This is arcuate fasciculus. If that conducting bridge is lost, conduction aphasia. There's a special area called angular gyrus. Angular gyrus is for reading from printed material and for naming objects. Two functions of angular gyrus, reading from printed material and for naming objects. So if there is any damage to the angular gyrus, the patient is not able to name objects. That is a naming disorder called anomic aphasia. They can't name objects. And they can't read from printed material. You give them a book or you ask them to read from a board, they can't do this. That is called dyslexia. Unable to read from printed material. It's a developmental disorder. From birth, it is present. It is called dyslexia. Suddenly, if you acquire in life, that is called alexia. So, in the movie Tare Zameen Par, dyslexia would have been clearly portrayed. So, this is about aphasia, different types of aphasia. What are the differences between Wernicke's aphasia and Broca's aphasia? Already we saw this. Damage to area 22 is Wernicke. Damage to area 44 is Broca's. In Wernicke's aphasia, it's called sensory aphasia because it is helping you in comprehension. It is receiving the word first, receptive aphasia. It is sensing the meaning of the word, so sensory aphasia. Comprehension is lost, fluency is not lost. So how will this patient speak to you? Comprehension is lost, so meaningless. He is not able to understand any meaning, meaningless, but fluency is not lost. Fluent speech. So we saw this, right? You ask him to say, Betty bought some butter. How will he say this? Butter, 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 butter. See, there's no meaning at all. Meaningless, but he is speaking fluently. So he is creating his own new words. That is called neologism. Recently asked NEET exam question. Neologism is seen in Wernicke's aphasia. One severe form of Wernicke's aphasia is jargon's aphasia, where the patient is not understanding anything. When you talk to him, he can't understand. When he is talking to you, you can't understand. This is jargon aphasia. Whereas Broca's aphasia, damage to area 44 on the frontal gyrus, motor area for speech, helps in producing motor speech, helps you to express the word. So it is called expressive aphasia or motor aphasia. So here, comprehension is not lost. So whatever you talk to him, he is understanding the meaning, meaningful. But fluency is lost. Non-fluent. Meaningful but non-fluent. So you ask him to say Betty bought some butter. How will he say? Betty. Bought. This is a stuttering or stammering type of speech. One cause of stuttering or stammering speech is Broca's aphasia. It's over to the visual pathway and the clinical importance. Very, very important in ophthalmology also. The visual pathway. First, let's understand the visual pathway as such. Then we'll do the clinical correlations. So in the visual pathway, first of all, there is a crossing over. See, you can see some crossed arrow marks. What is this crossing over? This is the right eye and the left eye. Let's say, look at me. I'll take my right eye. I'll open my right eye. For my right eye, this is the temporal or the lateral field because temporal bone is here. Now, only for my right eye. For my right eye, the pencil is on the temporal field. Now it is on the medial or the nose is there, nasal field. Now it's on the superior half, inferior half. Whenever you look at any object, any field, all objects on the temporal field or lateral field will cross and fall on the middle half of the retina. All objects on the medial field will cross and fall on the lateral half of the retina. Objects on top will cross and fall on the inferior half. Objects down will cross and fall on the superior half. This is the complete crossing over that happens. What happened? You're not seeing the screen? Just a minute. Yes, I hope you're seeing the screen now. So this is the initial crossing over that happens. After that, the impulses are taken by optic nerves. Optic nerves go as medial fibers. The blue one is medial fiber and the red one is lateral fiber. When they move towards the optic chiasm, see, medial fibers, lateral fibers, both the medial fibers cross at the optic chiasm. Lateral fibers go uncrossed. So at the optic chiasm, only the medial fibers are crossing. Lateral fibers go uncrossed. After that, they form the optic tracts. Optic tract reaches lateral geniculate nucleus of thalamus. Lateral geniculate nucleus of thalamus has 6 layers. Layers 1 and 2 form magnocellular pathway. Magno means big. So it is responsible for bigger movement and bigger depth. Layers 3, 4, 5, 6 form parvocellular pathway. Parvo means small. Parvovirus, smallest virus. So this is responsible for small details like textures, colors and shapes. And all of them will reach layer 4 of the primary visual cortex. When they touch the occipital lobe, the primary visual cortex, you are able to see things. So this is the visual pathway. More important, defects on the visual pathway. We'll do only right-sided defects. Let's start with the right side optic nerve. If there is any damage to the right side optic nerve, this is the right field and left field, you will not see anything on the right eye because right side optic nerve is cut, right eye blindness. This is called monoocular blindness. Monoocular means one eye is blind, left is normal. The second lesion, and there is any damage to optic chiasm. At the level of optic chiasm, what fibers are crossing? Medial fibers are crossing. Medial fibers will carry from both the eyes temporal or lateral field. So since medial fibers are cut in both the eye, temporal field will be lost. This is called bitemporal. Bitemporal hemianopia. Hemi means only half vision is lost. So hemianopia. Repeat question. The next one. When there is any damage to optic tract. Optic tracts. Let's say right side optic tract is cut. Look at this. Right side optic tract carries vision from, if this is cut, it will carry vision from the lateral half fibers of the right eye, which will carry from this field, and the medial fibers of the opposite eye, which will carry from this field. So in both the eyes, if you see, left half of the world he is not seeing. Damage is to the right side optic tract, but in both the eyes, left half of the world is not seen. Contralateral. Right side optic tract is cut, left half of the world you are not seeing. Contralateral. Homonymous hemianopia. Homonymous means uniformly. Hemianopia. Hemi means half vision is lost. Contralateral homonymous hemianopia. And after this, all the lesions are same. Contralateral homonymous hemianopia. Because crossing over is already done in the optic chiasm. After that, there is no more crossing over. So there's no change. It's all contralateral homonymous hemianopia, but with small changes. We'll see what are those small changes. If there is any damage to the superior optic radiation, superior optic radiation, superior optic radiation means only inferior half will be lost. So this is same. Contralateral homonymous hemianopia, but only inferior half is lost. So I can call it as contralateral homonymous. Now it is not hemianopia. Hemi means half vision should be lost. Here of the 4 quadrants, only one of the quadrant is lost. Which quadrant? Inferior quadrant. So it is called inferior quadrant anopia. Inferior quadrant anopia. Similarly, if inferior optic radiation is cut, contralateral homonymous, inferior is cut, superior quadrant anopia. You will not see only the superior half. Only one quadrant is not seen. Superior quadrant anopia. Ma'am, repeat. Dheeraj, which one you want me to repeat? Contralateral? So yes, contralateral homonymous hemianopia. I'll repeat again. Optic tracts are damaged. So let's say these optic tracts, right side optic tract is cut. So when right side optic tract is damaged, we will just trace the right side optic tract. It will carry the lateral fiber from the right eye, which will carry vision from here. And it carries medial fiber from the opposite eye, which will carry vision from here. See, I'll repeat, Dheeraj. This optic tract has lateral fibers of the right eye. From where will lateral fiber carry information, carry the visual field? It's opposite. So this medial field is lost. And medial fibers of the opposite eye, which will carry from lateral field. So overall, if you see, damage is to the right side optic tract, but left half of the field you are not seeing. See, in both the eyes, left half you are not seeing. That's why it is called contralateral homonymous. In both the eye, left half is not seen. Hemianopia. After that, it's all contralateral homonymous hemianopia, but with small differences. From lateral geniculate nucleus to visual cortex, these are called as optic radiations. You have superior optic radiation and inferior optic radiations. If superior optic radiation is cut, I told you after this it is all contralateral homonymous hemianopia. But what is the difference? Only superior fibers are cut. I already told you, all objects on top will fall on the inferior half of the retina. All objects down will fall on the superior half of the retina. So superior fiber is cut, inferior field will be lost. So I call it as contralateral homonymous. Inferior, இது இப்போ hemianopia கிடையாது. It's not hemianopia. Hemi means half. So it is one quadrant only is lost. So quadrant anopia. Similarly, inferior fibers are cut, superior quadrant anopia. Dheeraj, I think it's clear. Okay, over to the last one. Visual cortex. FMG repeat question. Right side visual cortex is damaged. So this is also very clear. Huh? Nice. So this is contralateral homonymous hemianopia with macular sparing. Your repeat question, macular sparing or central sparing. What is this macular sparing? See, the center alone is not affected. A small portion which is not affected. Center will escape because if you take the macula, let's take the right eye's macula. So this is the right eye. This is the macula. Macula is responsible for center vision. So if I'm looking at this classroom, all students sitting in the center will fall on my macula. So macula is responsible for center vision. But right eye's macula, it will have a representation on right side visual cortex, and also it is represented on left side visual cortex. Bilateral representation. So even if right side visual cortex is damaged, macula will escape because left side visual cortex is going to save the macula. If macula is saved, central vision will be saved. That's called central sparing. So that is why there's a central sparing. Okay. Quickly, now I'll show you the lesions. You tell me the finding. You tell me the diagnosis. Top one is always normal vision. So what is this below one? Both the eye, you are not seeing lateral half. What is the finding? What is the diagnosis? Bitemporal hemianopia. Good. Yes, all of you please. Bitemporal hemianopia. This one? Right eye, left eye. What is the diagnosis? Contralateral homonymous hemianopia. Can you tell me the site of injury? In both the eyes, left half is lost. Tell me the site of injury. Multiple times asked question. Don't make mistake. Yes, right side optic tract. Very good. Right side optic tract is cut. That is why left half of the world you are not seeing in both the eyes. This one? Yes, inferior quadrant anopia, contralateral homonymous inferior quadrant anopia. This we call it as pie on floor. A pie-like area on the floor is not seen. Inferior quadrant anopia, damage is to the superior fiber, superior optic radiation. This is pie on sky. This is called superior quadrant anopia. Damage is to the inferior optic radiation. Yes, this is superior quadrant, because superior quadrant is lost. Superior quadrant anopia. But where is the damage? Damage is to the inferior optic radiations. What is this? Macular sparing. Very good. Macular sparing. Yes, hearing, the last part of neurophysiology. We'll finish hearing this 5 more minutes and we'll go for the lunch break. Other systems will continue after the lunch. Nerve and neuro muscle. So we have finished nerve, neuro and muscle. So these are the most biggest parts of physiology. After lunch, we'll do the other systems. Hearing mechanism. How do we hear? Sounds enter into the ear, external ear, middle ear and the inner ear. Inner ear has cochlea. Cochlea is responsible for hearing. Inner ear also has semicircular canal, atricle and saccule. They are called vestibular apparatus. Vestibular apparatus. Vestibular apparatus is for balance. Cochlea for hearing, vestibular apparatus for balance. If you zoom into the structure of the cochlea, this snail-like structure is the cochlea. If you zoom into this, it will look like this. Cochlea has upper membrane called Reisner's membrane and lower membrane is basilar membrane. The two membranes are dividing the cochlea into 1, 2 and 3 zones. The top scala vestibuli and bottom scala medii, the top scala vestibuli and bottom scala tympani, both are rich in sodium and the fluid in them is called perilymph. The middle scala media is rich in potassium and this is called endolymph. This only is important for us because the potentials developed in the endolymph is called endocochlear potentials. Remember, scala media is rich in potassium. When you zoom into the scala media, you can see the organ of corti. which has the receptors for hearing. I will zoom into the organ of Corti. It will look like this. On the basilar membrane, organ of Corti has hair cell, supporting cell, dater cell, and pillar cell. Hair cells on top, they are connected to the tectorial membrane. Whenever any sounds enter inside, your basilar membrane will move. See, look at me. If basilar membrane moves, this is going to push on the hair cell. Hair cells are of different heights. Shortest one is called stereocilium. Tallest one is called kinocilium. So when sound enters, basilar membrane moves, it will push the stereocilium towards the kinocilium. Short ones are moved towards the taller ones. They are all connected by tip link. So when this tip link moves, see, stereocilium moves towards the kinocilium. They are all connected by tip links. When this tip link moves, there is opening up of cation channels. And a cation enters inside. Which cation will enter inside? Answer me. Which cation? Yes, Suvanil, very good. Potassium enters inside. Why potassium enters inside? Because all this is happening on the scalar media, and scalar media is rich in potassium. So this is the hair cell. So from here, potassium will enter into the hair cells. And this is the only exception in the body where potassium influx is going to cause depolarization. Listen, everywhere else in the body, depolarizations are due to sodium influx. One exception where depolarization is due to potassium coming inside is in the ear. Another exception where depolarization is due to calcium influx. Can you tell me this? Where is it due to calcium influx? Dheeraj, no, not NMJ junction. In neuromuscular junction also, sodium came inside and therefore you had depolarization. Depolarization will open up voltage gated calcium channel. Don't confuse this. Remember the first step, sodium came inside. That is why you had depolarization. That voltage is sensed by voltage gated calcium channel. Heart, Sonal, you are very close to the heart. Little more. Where in the heart? Ryan, not skeletal muscle. Skeletal muscle, sodium influx only. SA node, your pacemakers. SA node, very good, Dheeraj. Pacemakers and also smooth muscles. Please note this. Everywhere depolarization due to sodium influx. Only in the ear, potassium influx. SA node and smooth muscles, calcium influx. So here, potassium enters inside. Whenever any positive charge enters inside, there is depolarization and action potential. This action potential is carried by 8th cranial nerve. And from 8th cranial nerve, it is taken to the temporal auditory cortex. This pathway is called ecolema, very important ecolema. E for 8th cranial nerve, C for cochlear nucleus, O for superior olivary nucleus, L for lateral lemniscus, I for inferior colliculus, M for medial geniculate body, and A for auditory cortex. Ecolema. This is very important, repeatedly asked question. The pathway is called ecolema. The mnemonic is ecolema. Yes, we have finished nerve, muscle, and neurophysiology. With this message, married man's brain is divided into two parts, right and left. In right, nothing is left, and in left, nothing is right. So I should be the only married woman here. So with this, let's go for the lunch break, and we'll continue after the lunch break. Before that, I just wanted to show you this QR code. So you can just scan this and join the group. so that you'll keep informed about the timings of the break and all. So please scan this. And with that, let's go for a happy Sunday lunch break. Thank you so much to all of you. Maybe after 40 minutes, we'll join back. Yes, 1:05 now. Maybe at 1:45, maximum by 1:50. Come back by 1:50, maximum by 1:50. So back at, I'll write 1:45, then only you will come by 1:50, 1:45 p.m. Thank you so much, Swanil Guha. Thank you.